and I'll start.
Yes, Dr. Start.
So, good afternoon, everyone, and welcome for the today's web meeting. My name is Dr. Sanjay Kamble. I'm heading the team of medical at Samartha Life Sciences on behalf of medical team, the Samartha medical team, marketing team, and sales team. I welcome you all for the today's event. So, before we go on to the event, let me introduce our company first. Our vision is to be an innovative global health company that adds life, as well as we have a proud heritage of passionate, committed people and who are into innovative and differentiated products that makes people life better. So that was our aims and vision. And now let me tell you of something about the company. It started way back in 1963 from a small, that was a first generation entrepreneur. And now today it's a very big multinational company that has its presence in various countries like South America, UK, Southeast Asian countries, and many African countries. So Samartha has its presence international as well in other countries like Russia, Poland, Spain also. And overall, we cater to more than 35 countries over, and we market 250 products in the countries. So to do so, we have two formulation plants at Baddi, that is Himachal Pradesh, and a R&D center at Bangalore, wherein we manufacture various products which are critical care products, lyophilized and anti-cancer formulations, hormonal injections, tablets, and creams. And all of these businesses are divided into various divisions. So we have a total of 10 divisions in the organization which caters to all of these businesses. And and hence now this has been our marketing capabilities that has grown the business into the company which we are in today now. So that was about the company, and we do believe that for a company to grow, we have to be very much medically oriented, and to do so, we obviously uh, join hands in hands with the healthcare providers and having activities that really help to empower the knowledge of the physicians and which may definitely percolate as a better patient care. And that's the reason we have this activity of today, a webinar on N-Butyl cyanoacrylate, on which very shortly Dr. Kalpesh Jani would be speaking about as an expert. So it's my now privilege to welcome Dr. Kalpesh Jani. So Dr. Kalpesh Jani is a consultant GI and minimal access surgeon at Baroda. Uh, because Baroda. Sir has more than 55 journals, articles to his credit, which are published in various international and national journals, as well as he has chaptered 7 books. Dr. Kalpesh has more than 300 attended more than 300 conferences, which are national and international. Uh, has developed various procedural videos, which are in the Library of American College of Surgery and SAGES. He is the president-elect at Association of Medieval Access Surgeons of India. He is the executive committee member at Hernia Society of India. He is a journal editor of Minimal Access Surgery, editorial board member of 12 international accredited journals, and his innovations include retrorectus onlay mesh, repair for ventral abdominal wall hernias, critical circle of fundoplication, concept for creation of mathematically precise, identical, replicable wraps, N-Butyl cyanoacrylate glue fixation for mesh in laparoscopic groin hernia repair, and internal oblique aponeurotic flap repair for open groin hernia repair. So with this short introduction, it's really our pleasure to hear more about his work regarding the N-Butyl cyanoacrylate for the today's topic. So I welcome Dr. Jani to begin his presentation. And so, Dr. Jani, over to you. I'll just stop sharing my slides and you can share yours.
Right. Good afternoon, everybody. So at the outset, I would like to thank both Dr. Sanjay Kamble and Ms. Bhagwati from Samarth Pharma for this opportunity. We have been getting a lot of queries in the conference, a lot of the surgeons, friends across the country. Whenever I talk about mesh fixation and our own technique, they want to know how exactly to do all this. So this is a great way, to reach out to so many of them. What we can do is for the question answer sessions, people can type in their questions into the chat box. So we'll take at the end. And I'll immediately right now, we'll just go to the presentation itself.
Yeah, slides are visible, so you can.
Right. So basically, we are going to talk about how to use the N-Butyl cyanoacrylate mesh. We primarily use it in TEP. Most of our groin hernias are TEP using the triangulation method, what is now known as the PTAP method, and not ETAP, but the PTAP, P for Dr. Pallimelu's technique. So that's the PTAP technique. And we also use the NBCA glue for mesh fixation in SCOLA whenever we do SCOLA. So I'm going to talk about these two usages. So basically, mechanical mesh fixation in lap hernia surgery was traditionally using tackles and sutures. So initially it started off with tackles because tackles were costly. Many surgeons, including ourselves, we started initially using sutures to fix the mesh. Taking sutures with initially we started with polypropylene, then we shifted to polydiaxonon and fixing the mesh to the Cooper's ligament and rarely at two more points proximally. But all the data shows that this sort of mechanical mesh fixation is associated with chronic postoperative groin pain. There's an increased incidence of chronic postoperative groin pain. So to obviate this, in the Western literature, they started using fibrin glue. Now the problem with fibrin glue, of course, it is that it is extremely costly. I think a single usage costs somewhere around 10 to 12,000 rupees. So obviously that goes out of, it's not feasible in India, that sort of high cost. The bonding is weaker, and potentially before previously when the pipeline route came out, it used to be animal source. Nowadays, even a human source fibrin glue is available, which is even more costlier. But with the animal source fibrin glue, there was all the potential of the patient developing an allergenic reaction. So NBCA glue mesh fixation was first reported in open Liechtenstein hernioplasty way back in 1993. And in its first use in lap TEP hernioplasty, this is what I came across when I was, in 2003 when I started using glue for TEP. They reported a couple of 3 cases these were by some British surgeons in 1998. Unfortunately, I never found them, to proceed with this concept, and that was the only report that I could come across when I started searching the literature way back in 2003. Now, let us talk about cyanoacrylates. Cyanoacrylates, are a type of synthetic products. They are synthetic glues, and they rapidly solidify when they come in contact with, weak bases like water and blood. So they are ideal for use in the humans, and they are easy to apply. And because they are easy to apply, it's very fast, the application. And secondly, the other important part, especially for our country, was that they are quite cheap also. There are various esters available of cyanoacrylate. When you say, that's why we don't say just cyanoacrylate. We always specify what ester we are using, what polymer we are. Various polymers are available, and what polymer we are using. So previously, what was available was methyl and methyl cyanoacrylate, but these were primarily used in a commercial glue. And then we had the N-Butyl. After that, we had isobutyl, one of the other monomers. And finally, we had octobutyl, which is a recent entrant. Now, because of the different characteristics, you can see because methyl and ethyl, when they were deployed, they would liberate formaldehyde, which was, of course, cytotoxic as well as carcinogenic. So they cannot be used in human beings. They were mainly used for in commercial application. But N-Butyl cyanoacrylate was very ideal for human use because it was slow. It degraded quite slowly. So its effect persisted for a longer time. There were minimal side effects, and there was very strong rigid bonding with that. It also had bacteriostatic activity. So there was another monomer called isobutyl, but that is not available. After that, we had octyl cyanoacrylate. So that's also approved for human usage. But the reason why I choose N-Butyl over octyl is that the bonding in octyl is weaker as compared to N-Butyl, and also it solidifies little. It's a little slower in its application. So I'm very comfortable with N-Butyl, and of course N-Butyl is again much more cost effective, economical as compared to the octyl monomer. So N-Butyl has certain advantages also. When you spray it across, it achieves minor oozing. It will immediately stop if there is any minor oozing. So that is helpful more in SCOLA rather than in TEP hernioplasty. Easy to use, as I already mentioned, that it has a very fast action, and it has also bacteriostatic properties. Bacteriostatic properties are not very important, but in the sense that it definitely won't increase the risk of infection. Now, when we first started using, of course, glues were already been available at that time also, but they were used for cutaneous closure, for skin closure. Now, since I wanted to use the glue inside the body, we had to use a polymer variant that was safe for intracorporeal use. And N-Butyl has a very long history of safety in human beings. The first reported use was of NBCA glue was for the treatment of gastric and acute bleeding varices way back in the 1990s, 1980s, late 80s. And since 1990, I think, or 91, it has got FDA approval for human use. You can actually inject it into the blood. That's how it works in esophageal varices. It's an intravaricial injection. So you actually can put it into the blood, and it doesn't cause any reaction or any carcinogenic effect. So what is the mechanism of action is that we already talked, that it's a watery solution, and when it comes in contact with blood or body fluids, because they are weakly alkaline, it just takes 20 seconds, and in fact, even less than that, in just 20 seconds, it solidifies and fixes the tissue, and in our case, it will fix the mesh in its position. So you just have to hold the mesh in position after spraying the glue. You just have to hold the mesh in that position for 20 seconds, and then the mesh remains fixed in that position. So this was we were one of the first to do an RCT for glue use. As I said, we used to do before using the glue, we used to do suture fixation, but we carried out a randomized control trial of NBCA glue fixation versus suture fixation from 2003 onwards, and then we even reported 5-year results. So this paper was published in 2016. We showed that there was a lower incidence of chronic groin pain. And in fact, this was a meta-analysis that came out in 2021 of glue versus mechanical fixation, where I'm very happy to say that they actually took our paper also in, as it was one of the earliest papers. Our paper is there as part of the RCTs. It's a meta-analysis of RCTs, and it showed that it was associated with lower risk of chronic post-operative inguinal pain, glue use. And hematoma also they found, of course, we did study for the hematoma risk, but the hematoma they found that was less as when you are using glue as compared to suture fixation or tacker fixation, which would, I guess it's common sense, because when you are using a mechanical or invasive fixation, there is a little chance that you are going to injure smaller vessels and cause some amount of bleeding or hematoma formation. And the conclusion was that glue-based mesh fixation decreases the risk of chronic post-operative inguinal pain as well as hematoma after laparoscopic inguinal repair as compared to mechanical fixation. There are other studies which have compared glue versus not only suture in open hernioplasty. They also found that the pain after using glue, of course, we don't do so much of open, but then those who are doing open frequently, they can also consider using glue if you are doing the Liechtenstein repair for fixation instead of using sutures. This was another study, and they showed that it reduces the chronic post-operative pain. This was another study which compared in laparoscopy, which compared glues against tackers. We had compared it against sutures. They found that not only was it significantly cost-effective, obviously tacker is a costly prospect, but again, even against tackers, there is a significant reduction in post-op pain and as well as chronic pain beyond 6 months of surgery. So now we'll just go to the technique of surgery. How do we deploy the glue? So once this is a case of bilateral groin hernia. Once both the meshes are deployed, you spread them out, I am not covering that. Then what we do is we take space 2 centimeters above the pubic symphysis. So I just take 2 finger breadths above and through the skin. Before this, the skin has been painted and cleaned with povidone iodine solution, so betadine solution, and then through the skin I pass a 20 G spinal needle. So it's a disposable spinal needle, very cheap again, costs just about less than 100 rupees, and then you spray the glue onto the mesh and onto the Cooper's ligament, and you can see I'm easily holding the instrument there. Initially, when we started off, we were worried, that the glue would go into the instrument and it would fix, the instrument would get used. But as I said, the glue does not truly solidified unless it comes in contact with a weak base. So because this is stainless steel, it is inert, it doesn't damage the instrument. At the most, the glue may form some encrusted on top of the instrument, which you can just clean with a gauze piece soaked in spirit. And you just have to hold the mesh in position for 20 seconds only, or 20 to 30 seconds. And then the mesh remains fixed in that position. And then you can go for a controlled desufflation. So that was the glue used in NBC for groin. Now, as I said, as I mentioned earlier, we also use glue in our SCOLA repairs. SCOLA repairs, as you know, it basically was described by an Argentinian surgeon called Klaus. The full form stands as subcutaneous only laparoscopic approach. Klaus had basically, and his team had basically described it for diastasis of rectus abdominis muscles and epigastric hernias. We primarily use it for diastasis whenever, especially if there is a small umbilical hernia. Most of the time, your rectal divarication will be associated with small umbilical hernias, and these are the cases where you can ideally deal with, SCOLA. It has the SCOLA is also known by different names at other centers like Tesla or REPA or LR, but all of them basically describe the same underlying technique. So this is how our trocar position will be there. This is the costal margin, and we'll be standing at the foot end of the patient between the legs of the patient. This is the typical divarication that you have with sorry, this is the epigastric end. This is the costal margin. Please excuse me. This is the costal margin. This is the anterior superior iliac spine. This is the pubic symphysis, and the surgeon is standing between the leg ends of the patient, looking up, right? And this is the divarication with the umbilical hernia. So first, again, the same thing happens. I won't describe the surgery of SCOLA over here. You have to go in the subcu plane right over the rectus sheath and the lateral external oblique aponeurosis, create the plane over there, do the dissection, do the divarication repair. And once you finish the divarication repair, you measure the mesh size that is required and deploy a fairly the large size. So this video is, since it deals only with the glue used in this, once you deploy a mesh, you adjust the mesh. So this would be our, as I said, I would be standing in a split leg position. I'll be standing between the legs. Our typical port position, suprapubic 10 mm and 25 mm on either side. We, as I said, we deploy a mesh. The mesh is cut in a sort of a rhomboid shape to accommodate the shape of the abdomen, just as you trim the mesh in groin. In the same way, for a SCOLA, you trim the mesh in contour with the abdominal wall. We take two fixating sutures with the muscle aponeurosis below in a cross-shaped fashion, one at the upper end, one at the lower end, and one each on either sides. So this you can take using either PDS suture or Vicryl suture. And this I think we use on Vicryl, or you can even use a polypropylene suture. Any will do. But I prefer absorbable sutures over here. So one at the upper end, one lower end, and then one on this is on the left side. And similarly, one on the right side. We don't need to constrict that. And then in the same way, we put a spinal needle, disposable 20G spinal needle. And you can see that I'm spraying the NBCA glue in each quadrant. And because the spinal needle is long, through each puncture only you can reach on each side. So one puncture for the spinal needle on the left side, one on the right side. Hold it in position for 20 seconds only till the mesh gets fixed in position. And because this is SCOLA, one of seromas is one of the known side effects. So you put a negative section drain, then you come out. Right. So that's the end of the talk. If there are any questions in the chat box or something, if anybody wants, or maybe if somebody's, I think we are gone live on the YouTube. So if somebody is watching the questions on the YouTube channel, maybe you can.
Yes. We are getting some questions, sir. So just let me go through the questions. But before that, indeed, it was a very nice presentation, very practicality, applicability of the glue that you have demonstrated in the video. That was very much exciting. So there are a few questions. So the first question I would take is what is the possibility of neuralgia with the glue? Is it common? Is it reported, or is it not common, not seen in the
So,
glue?
yeah. So actually, that's a very good question in the sense that the chronic postoperative groin pain that happens with mechanical fixation. It has two etiologies. One etiology is, of course, because it damages the osteum, it can cause, osteomyelitis also. So that could be one of the pain. But the second possibility is nerve entrapment under the tackers or the suture. If you hit any nerve and it gets entrapped, especially if you are putting the fixation laterally. In glue, because you are just spraying it on top, there is no possibility of there going to be any injury to any nerve. So there is absolutely no possibility of any neuralgic pain because of glue fixation. If there is neuralgic pain, it is because of the dissection that you have done for the hernia, not because of the glue. Glue will never cause any sort of neuralgic pain.
So thank you, sir, for that wonderful answer. There's one more question which has been asked is what is the quantity of glue that is usually required
Yeah,
for the
I
application?
was I was waiting for that question. I thought if they won't ask the question, then I will answer. This shows that people are watching our videos, our talk. So yes, as I said, so what will happen is that for groin hernia, we use zero point 0.5 ml of Endocryl. Endocryl is the brand that I prefer. That is the Samat Pharma's brand. So I use zero point 0.5 ml of Endocryl per side. So if it's a unilateral, I'll use zero point 0.5 ml. If it's bilateral, it will be 0.5, 0.5 in each side. That is 1 ml in one syringe, 2 cc syringe. If it's unilateral, it will be 0.5 ml in a 2 cc syringe, and then you spray it. And for SCOLA, we use 1 ml for each side. So that will be 2 ml. 1 ml on left side, 1 ml sprayed on right side, and that will be 2 ml.
Another question is what should be the minimum gauge of the needle which is used to inject the glue?
So
You said, yeah.
20G. Yeah. We initially started with thinner needles, thinner spinal needles, because we thought why fit a larger puncture. Then we found that if you're doing it a unilateral side, only one, and you are going to spray it only once, then you can even put a thinner spinal needle, a 22 or a 23G spinal needle, that will work. But if you're going to two side, what will happen is that you spray on one side, hold it for 20 seconds, then turn the needle to the other side, and the thinner needles we found tended to get blocked in that 20 to 30 seconds. So then we shifted to using that the 20G needle, and anyway the puncture mark, whether it is of 23G or 24G, patient is never going to, or a 20G, a patient never notices it. So it's too small a puncture mark. So I think now universally we have started using 20G spinal needles, the yellow one, it has the yellow marker code. It's a yellow colored spinal needle.
Okay. The follow-up question to that is that if the glue is been injected where it has to do the mesh fixation, and after this distilled water is to be injected, and if how much ml usually you do it?
So what happens? The reason I think the participant is asking is that because some glue will remain the needle. So that again is a very good question. What happens is that, so for example, if I had to take a spray on both the sides, so I'll take 1 cc of glue in a 2 cc syringe, 2 ml needle, and remaining 1 cc I'll fill up with air. So when I spray it, I spray half ml on one side. When I spray half ml on the other side, the whole half ml won't actually spray on the other side. There will be some amount of glue which will remain in the needle itself. If I wouldn't have pulled up the air behind it. So when I push the air in, it gets completely empty and the whole half cc gets sprayed over there. So no distilled water. Only you fill up the back side should be filled up with air, and when you spray it, push the air at the end so that the whole needle gets sprayed out. Same thing will hold for SCOLA also.
Okay. So there's another question which is coming. What I see is that if there is a viscera or a proximity of a vessel where you're wanting actually to introduce the glue into. So what is to be done?
Basically,
Do we
glue,
do?
you can't use the glue on top on a viscera. So that's why we don't use it for intraperitoneal repairs. That's why in IFOM we don't want to use it the glue because it can fall into the ball itself. So that's why extraperitoneal, when you're doing a TEP hernia repair, there's not going to be any viscera over there. It won't cause any problem if a few drops fall on the urinary bladder or something like that, or on top of the vessel also. It doesn't cause any problem. As I said, the glue itself has been safely used for injection into the varices, right inside the lumen of the vessel. It blocks the lumen of the vessel. And so obviously, when you're using it inside the esophagus, there's going to be some glue which will come out and fall on the esophageal mucosa. So it doesn't cause any damage over there. That glue doesn't cause any damage over there. So we know that it is safe for intracorporeal use. So you can very safely use it. Only you don't want to use intraperitoneal. So it's not yet been shown that it can be used intraperitoneally. That's why we use in extraperitoneal conditions like SCOLA and this thing, TEP.
Okay, so sir, how long one needs to wait after the application? How much seconds or till how long we wait once the glue is applied?
Yeah. So basically, as the glue, the scientific material tells us, the glue solidifies by 20 seconds. I give 10 seconds extra. I usually wait for about 30 seconds after spraying the glue.
Okay.
And you can see after that, then, the whole thing, that part will become fixed over there. You can actually see.
Yeah. There's another question which I see here is about the inguinal hernia. So the question is it strong enough or does one need to add a suture also or a bone fixation?
No, so we have done now, I think, as I said, I started doing it from 2003. Now we have got experience of something around 2,300 cases plus of TEP, and we have never had, a recurrence following, glue use in TEP hernia repair. So absolutely not. No suture fixation is required. Glue itself is sufficient.
So I suppose are there any? Let me see in the chat box as
Yeah. So I
well.
can see some
Yeah,
questions in the chat box. Let me take them one by one.
yeah.
So Bhavesh Patel has asked any reaction of the glue? No. So this glue, as I said, is already safe, has been proven. It has been used since the late 80s, early 90s for intravariceal injection. It is known practically. If you see basically the glue that is available initially is available for, is the same glue is also available for varices. And if you see the adverse reaction in that, allergic reactions are extremely, extremely rare. They say practically don't mention it. Dr. Ajay C. Chauhan has asked, is this glue applicable in all cases of hernia? Well, I use it for all cases of TEP hernia surgery. I use it in all cases where I do SCOLA. So that I do not use it when I do TAPP, because in TAPP, I prefer to fix it at 3 points. But I do TAPP fairly less in very selected cases when I have very large sliding hernias or huge complete hernias where you want actually good fixation, because otherwise the whole mesh can slide down into the hernia where there's a complete board or the posterior inguinal wall. So those are the cases I would not use a glue for TAPP repair. Dr. Malik has asked, any incidence of mesh infection after glue usage? No, haven't had, and you won't have, because the glue, as I mentioned, it's meant for intravenous use for variceal injection, so it is absolutely sterile glue. If you have a mesh infection, it is because of your instrumentation is the hernia process itself is problem. The sterility chain has not been maintained in either the usage of deployment of the mesh or the instruments or something. Instead of needle from the outside, can we use laparoscopic suction needle for glue? I would not use a laparoscopic suction needle for glue. As I said, that the glue can block the needle, and laparoscopic suction needle is, of course, a reusable instrument. It is supposed it's a costly instrument. While a disposable spinal needle is it's very cheap. It's just, as I mentioned, it comes 65 rupees only. So why do you want to use something very costly with a chance of it getting blocked when you can get the same effect using something like 65 rupees. Uh, Let us see some, but instead of yeah, do we need to use tacker along with glue? I've already answered, no sutures, no tackers with glue. It's sufficient. How will you use in IFOM? I do not recommend using N-Butyl cyanoacrylate. I think you should not be used along with IPOM repair in ventral hernia, because we don't know what happens if the glue falls onto the intestine and the two intestines can stick together. So better not to use for IPOM, intraperitoneal use. It's always better to avoid. Many surgeons do not fix the mesh in tap. So yes, this is definitely, is mesh fixation really required? Well, mesh fixation, there are many people who say we don't fix the mesh. Absolutely fine. So if for those who are not fixing the mesh, you have to remember you have to create very limited space so that the mesh, does not have any space to move around in the next 72 hours. So the surgeons who don't know how to put a mesh will have to do a limited dissection. I usually like to do a very wide dissection. That is what we do in a P-tap repair. Similarly, that is what you do in an E-tap repair. When you do a wide dissection, you can deploy a very large mesh. We deploy typically a 15 into 13 or a 12, 13 or 14 centimeter mesh, so that it opens out very easily. So there is a wide space created. When you have a wider space created, there is always a chance that the mesh, in the image, if the patient has a post-operative bout of vomiting, coughing or something, the mesh can get displaced. So I would prefer to fix a mesh. Mesh fixation, as I said, especially when you're using glue, does not take any time at all. It takes me about maybe 1 or 2 minutes at a time. I can sleep very peacefully at night. So I prefer to fix the mesh in TEP hernia repair. And for TAPP, as I said, especially because of my selection of cases is such in TAPP, they would require mesh fixation. For how long the glue is going to hold the mesh, any sort of mesh fixation that you do has to work only as long as the time it takes for the mesh to get incorporated. So typical granulation ingrowth will start within 6 hours, and by 72 hours, it has been shown in animal studies that preliminary ingrowth has occurred to hold the mesh in position. So you need, unless there is a massive trauma, in that region, which is going to, like a patient has a car accident or something like that, that is a different story. But otherwise, you need to hold the mesh in position only for up to 72 hours. After that, it's going to get fixed quite nicely. After fixation with the guest, Dr. Jinesh is asking, how does the mesh behave as far as mesh shrinkage is concerned? I would not expect any, because as you can see that, we don't do wide spraying of the mesh. We just fix it in points. So the mesh fixation, mesh shrinkage would be, occurring in the same way as without with the glue. I have not seen any study which has, compared mesh shrinkage with fixation and without fixation, or with glue and without glue. So I wouldn't be able to really answer that. But logically speaking, I don't think it's going to impact the mesh shrinkage at all, because the mesh shrinkage is actually a function of the surrounding, the ingrowth and the fibroblast of the occurring, and that actually occurs as much as possible. And a corollary of this is that you should not be spraying a huge amount of glue, because you want to keep the most of the pores open, because the pores of the mesh will allow the ingrowth to take place and will allow the mesh to get incorporated and firmly fixed. So wider spraying of the glue, covering a large amount of area with a large amount of volume of glue, is actually not recommended. It is contraindicated. So this is the optimum amount that you just as you would fix at one point in a mesh or with a tacker, same way we fix one point with the glue. Is there possibility of displacement of mesh in late postoperative period? Well, as I already mentioned, late postoperative displacement does not, if the mesh displacement, if it occurs, it will occur in the first 72 or maybe at the first 96 hours. After that, it's extremely unlikely unless the patient is a major trauma. Any dilution? No dilution. It is directly 0.5 ml. Sorry. And let us go down for that we have answered. My friend Alfiza, is there any reported allergic reaction to the glue? I have not yet come across to NBCA. To the previously, now, even for the skin glue, they give the same NBCA glue. Previously, one of the other polymers was given, which was not recommended for intracorporeal use, which was available as a glue for skin fixation, for skin closure, and there were some local skin reactions with that glue. But now, after, I think all the companies give the same NBCA glue, for skin, or octyl cyanoacrylate for skin closure also. If peritoneal injury in a team, well, if there is a peritoneal opening or rent, you obviously, if you are doing a TEP repair or in SCOLA, obviously there would not be a this, but I assume you are talking about TEP. You would have to close the rent before you deploy a proline mesh, because you are deploying a proline mesh over the and over there. So if there is the place where we are spraying the glue, there is no peritoneum. There will be just urinary bladder below that. The peritoneum won't come over there. So if there is a major rent proximally, you will obviously go in a small. Proximally, the glue is going to solidify its way down over the pubic Cooper's ligament, over the no, pubic symphysis. So it's not going to cause any problem over there. Whether it's only to be applied to the Cooper's ligament, well, that's my practice. I was fixing the suture fixation to the Cooper's ligament, and because when I did my first RCT, I wanted to keep everything equal. So the RCT compared, suture fixation and glue fixation at the same point over the same area of Cooper's ligament with similar long-term results also. So yeah, and then after that, because the results were good, I just stuck to Cooper's ligament. But otherwise, there is no as such rule that you have to fix it over Cooper's ligament, but it makes sense because there's no vital structure over there. So that's the safest place where you can, no nerves come over there. So that's the safest place you can fix it. If it falls on the triangle, if it falls from outside, nothing will happen. If it falls on any vessel or something, small vessels on the outer surface, it doesn't cause any intimal damage. And anyway, those triangle of doom area, there would still be a lot of fatty tissue, fibrous tissue over there. So it won't cause any issue. The mesh is on top of that, and you are spraying on that. So it doesn't cause any issue. Can we use it in a rectorectus mesh repair? Yes, absolutely. You can use it if you're using a plain polypropylene mesh. That's another story again. For all my rectorectus mesh repair, most of you probably know that we innovated the ROM repair rectorectus only mesh that we do, and we are using a self-fixating mesh that is made by another company, which has barbs on one surface and polypropylene, which are absorbable, polyglided by barbs on one surface, which we keep to the muscle side, and a polypropylene polyester mesh on the other side towards the posterior rectus sheath. So since we use this self-fixating mesh, it doesn't require any sort of fixation. You just need to orient the mesh with two trans fixating sutures in the midline and just open up the mesh and it sticks in position. Tanmay is asking, better than absorbable tacker. Well, yes, absolutely. I would say cost effective, definitely. Because 0.5 ml of glue is available for hospital supply rate. I mean, the brand that I use, Endocryl, somewhere between 400 and 500 rupees, while an absorbable tacker, even if you buy the smallest one, with 12 tacker is, I think, around 12,000 rupees. So why won't you, when the same effect you can have with this thing, why not? And even an absorbable taker is associated with early postoperative higher pain as compared to this thing in the data. And secondly, for TP repair, if you read the company brochures, they do mention very clearly that absorbable takers are not meant to be used over any body structure. So you can't use it absorbable taker to fix over the Cooper's ligament. If you are using an absorbable taker in TEP hernia, you have to put it over the posterior aspect of the rectus muscle and the midline, and maybe laterally in the muscle. And when you put it into the muscle, again, you are likely to cause you may cause some injury to a muscular vessel. And that's the reason why there was higher incidence of postoperative hematoma in the study of tacker versus glue fixation. Whether it is advisable to use in open hernia repair, well, I already showed one RCT where they had used it and compared it to suture in open hernia repair. And I know several people, several very senior people who are now using glue regularly in open hernia repair. Since I myself do not do too many open hernia repairs, I am not the right person to answer this. The people that I know with whom I have talked, they fix the mesh at least one place when they are doing with open when they're doing for open hernia repair over the medial and the inferiormost aspect over the pubic tubercle, and then around the edges they spray the glue. So that is what I know, but I think the proper answer can be done by somebody who's doing a higher volume of glue fixation in open hernia repair. in ETAP RS or ETAP groin. ETAP groin hernia, obviously you can use. ETAP are basically almost similar. PTAP was promulgated earlier in '92 by Palnivel sir, a triangulation technique. So you can use it for ETAP. Definitely. Any effect on nerves if glue goes to posterior wall where in the medial aspect when you are putting, there won't be any nerves over there. So we won't, put it on then. And if you are talking, and even in SCOLA there are no nerves exposed. So yeah, I don't think the glue will be coming in contact with the nerves. If it comes on top of the gloves, I really don't know what happens if somehow if you spray it where there are nerves and but why do you want to spray it laterally? You spray it over the corpus ligament only. Single point is effective. Does cyanoacrylate dissolve after how long? Well, cyanoacrylate from the data that is available, it is, and from what I showed that, it remains there for some time. And after that, it provides fixation, something for, I think, 3 or 4 months, something like that. And then it disappears. So yes, eventually it will dissolve and disappear after some time, I guess. I think that's the end of the questions.
Yeah. Actually, it was, we really appreciate your patient answering of these many questions. But yes, there were very practical aspects which most of the surgeons would like to know. So thank you, Dr. Kalpesh, for your very nice presentation and the patient answers. I hope the delegates are satisfied with the answers, and we hope that this session of yours would definitely help all of us in better management or better usage of the cyanoacrylate glue in the practice. So with this, I suppose if there are no more questions, we can call it a day. And so before we finish, I would like to thank the first and foremost Dr. Kalpesh Jani for being with us for today's meeting, and all the delegates who patiently listened to Sir's talk. And of course, I would also like to thank the Alicia marketing team, Dhanashri, Mr. Shishir, and Shantanu, all the field colleagues, and of course, Anjana is from the medical team who is taking the minutes, and all the others whom I have missed. So thank you so much, and of course, Anilji, who is backing up the show with the Zoom links and other things. So thank you, and Bhagwati as well. So thank you, everyone, and that was indeed a very nice weekend to have enriched our knowledge. Thank you so much.